Thank you to Minister Humphreys for that kind introduction, for the meeting yesterday with the Premier and multiple ministers, including Transport, Planning, Environment, of course, Minister Humphreys as well. And, to all of you here who are present from so many sectors, not just the health sector, but also planning, transportation, and others. That has been really the key to success in the work that we've been doing in New York City, that we're also seeing in multiple communities in the United States and Canada. It is that intersectoral, cross-sectoral collaboration, co-leadership, actually, across different initiatives around improving our environments for health. So with that, I'm going to launch into the presentation and share some of our experiences and some of our lessons learned. And I'm very much also looking forward to hearing from the other speakers from New South Wales and to hear about your initiatives. So I'm going to start with a little bit of history. I think Chris mentioned that in very recent history, many of our approaches to prevention have been much more clinical and much more healthcare based. But if we actually go back a little more, back further into the 19th century and early 20th century, in fact, the roots of public health and the roots of prevention began with the built environment, with improving our environments, with planning and infrastructure of cities playing a fundamental role. So if we go back to the 19th century, infectious diseases were the leading causes of death. 19th century codes, planning, and infrastructure were used as weapons to battle these diseases because we didn't have the antibiotics, we didn't have the medical technologies at the time. But as you'll see in the presentation, these strategies were extremely effective and actually led to tremendous declines in the deaths from these diseases, even prior to the advent of many of our medical technologies. In the 21st century, we actually have a different set of diseases, chronic diseases. We can actually think of many of these diseases actually as diseases of energy. So for example, unhealthy foods, unhealthy beverages often result in too many calories ingested, which are a form of energy, and too little energy out in the form of physical activity and active living, another form of energy. Because of that equation around energy, many of the design solutions actually for the current health epidemics, in fact, parallel sustainable design solutions for the environment. And so we can actually make multiple gains by addressing common interventions. So we'll talk about that. Going back in history, this is 100 plus years ago in New York City, not so different from many of our cities around the world when we first started. The urban conditions were fundamentally a breeding ground for the types of epidemics that you saw. In 1910, there was severe overcrowding in lower Manhattan, approximately double the densities of today's Manhattan. In some of the wards, it actually reached over 400,000 people per square mile. That's 6 to 7 times what we see in Manhattan today. You combined with that inadequate systems of garbage, sewer, water, leading to pervasive filth and polluted water supplies. So if you read some of the history about Manhattan, you'll hear that the drinking water pond was actually a pond downtown that frequently had dead animals floating in it. Garbage would flow from the streets into it. We had many tenement buildings that had no windows. They were crowded, they were dark, they were dank. Our streets, actually, the buildings were set very tightly close together. And so light and air couldn't really enter the streets, and they would remain damp and dank, and puddles would remain there with mosquitoes breeding. So what were the types of diseases and epidemics that we saw? They were related to crowding and conditions where there was no ventilation, tuberculosis. Waterborne diseases like cholera were rampant. Vector-borne diseases spread by mosquitoes like yellow fever were rampant. So those were the types of epidemics that we saw. And what was the response? Well, as I said, many of the vaccines not available and our antibiotics not available. Response was really through infrastructure interventions. In 1842, after multiple cholera epidemics, New York City created the Croton Aqueduct, which was a new reservoir in upstate New York. We continue to use that reservoir today. And immediately after the formation of the Croton Aqueduct, those cholera epidemics went away and they never came back. 1857, Central Park was created, hailed as ventilation for the working man's lungs. So now people who lived in tenements can actually go to Central Park, get fresh air. And if you were not wealthy and had your own courtyard, you could still go out and get sunlight and fresh air. 1881, Department of Sanitation was formed to clean the streets of all the dead animals that would just be left there to rot, of the manure, horse manure that would pile up on the streets, of garbage that would be thrown on the streets. 1901, the Tenement House Act was passed and actually banned the construction of dark, airless tenement buildings. Now, all of a sudden, all buildings, including those tenement houses, had to have windows. Light and air could enter. Circulation of air could occur. 1904, the first section of the subway in New York opens, in large part to deal with the severe overcrowding in Lower Manhattan. Now people could live in Upper Manhattan, the Bronx, commute quickly into Lower Manhattan for commerce and for work. 1916, a zoning ordinance was passed. Buildings now were required to be stepped back a ways. Light and air could enter the streets. Those puddles dried up. The mosquitoes went away. And these were the results. 1880, leading causes of death, about 60% of deaths, infectious diseases. By 1940, before the widespread use of antibiotics, these infectious disease mortality rates had dropped tremendously to 11%. You could see that the gains actually between 1940 and today are actually relatively small, from 11% to 9%. So that is to say that the environments that we create through the work that we do in our societies is actually what determines the types of epidemics that we're going to see. So treatments are important once you get sick, but prevention is actually key. And prevention can only occur really through how, whether our environments are supportive or not supportive of the types of health conditions that are occurring. So today, of course, we've got a different set of diseases, chronic diseases, heart disease, strokes, diabetes, cancers, obesity as a leading risk condition. It is now the #1 cause of death globally, 36 million deaths a year according to the World Health Organization. Leading risk factors accounting for 80% of these deaths: tobacco use, physical inactivity, unhealthy diets, harmful use of alcohol. The red items, physical inactivity and unhealthy diets, as I mentioned earlier, linked to this energy equation of too much energy in, too little energy out. And as a consequence, there are linkages to environmental sustainability issues as well. Some of you may have seen these maps. They are maps of obesity in adults in the United States. 1985, the US Centers for Disease Control and Prevention began collecting data across states. You could see that when it began, there's no state with an obesity rate in adults above 14%. You'll see it change very quickly. 1991, a new color above 15%. It doesn't stop though. 1997, new color. Most states now above 15%, some states above 20. New color again, above 25. Majority of states now at 2001 above 20%. And so we're now at a situation where we have multiple states above 30%, no state left below 14%. And the vast majority of states above 25%. This is one of the reasons it's called an epidemic, the speed at which it's increased. In children, actually, the situation's increased even more rapidly. In the United States now, 30% of children are overweight or obese. In New York City, it's actually even worse, about 40% overweight or obese in our children. And so we have this issue that we really must address. And with that, type 2 diabetes has increased rapidly and are occurring at younger and younger ages that we are seeing. And of course, it's not only the health-related issues and the quality of life issues that people are faced with, but in terms of societal cost, there's a huge impact on medical care costs and healthcare costs, but also productivity costs from sickness absence, from disabilities related to these diseases. In fact, the situation is so dire that the UN in 2011 focused its General Assembly Summit in New York in 2011 on the issue of these chronic diseases. There was tremendous concern at what the healthcare costs were going to do to countries and societies, particularly developing countries where these diseases have recently overtaken infectious diseases as the leading causes of death. Now, in the US, $150 billion a year now spent just on the medical costs related to obesity. And if the current trends that you saw of rising obesity continue, by 2030, we're probably going to be spending about $1 trillion a year of our budgets on healthcare costs related to obesity. Now, you've seen how quickly obesity and diabetes have increased. And very frequently, I think we sometimes hear the debate, is it genetics, is it the environment? Well, very certainly our genetics have not changed in 2 to 3 decades. But if you look around us, our environment certainly has. It's getting more and more difficult to actually have to expend any energy in our daily life. We constantly rely on escalators and elevators when we go into our buildings. Many of us no longer walk to work. Our children no longer walk to school. Even if we wanted to walk, we couldn't because there may be no sidewalks, or if there are, the no intersections to cross the road. And then, of course, unhealthy, high-calorie, nutrient-poor foods are increasingly everywhere. Including unhealthy beverages. So, in the United States, in a place like New York, our newsstands used to sell only newspapers and magazines. And now every newsstand sells soda pop, potato chips. And so this pervasiveness of an availability of unhealthy food compared to healthy food is also something that we must address. At the same time that all of this is happening, our researchers have been hard at work undertaking research with support from research institutes and some foundations, looking at what factors might be important in addressing these issues. We also have the public health experience from the last few decades where we've tried health education and realized that, health education actually doesn't work if you don't have a supportive environment. We know people are getting the message because, every new year, what are some of the most common resolutions? People want to lose weight, they want to eat healthier, they want to basically exercise more. And yet, by February, most of them have given up. And they've given up because it is so difficult to do in the environment in which we live. And so this is the key factor, is that how do we support people in the choices that they want to make? Through a healthier environment, through an environment that makes it easy, not difficult, to make these choices. So the research is bearing out as well. It's showing us that if you design to increase active transportation through walkability, through good streetscapes, good footpaths, good bicycle lanes, transit orientation with availability of transit, safety on the streets from crime and from traffic-related issues, good lighting, good aesthetics, including landscaping and street trees and greenery, well, that can actually increase walking and physical activity by 35 to 160%. If you design to increase active recreation, so for example, there are parks and playgrounds and exercise places near where people live and work, children and adults will get more exercise and leisure time, and they're associated also with healthier weights. If we design to increase stair use in everyday life, some people have said, what can a little bit of stairs do for me? Well, caloric burn calculations in the United States, actually, by physical activity experts, suggest that if the average American adult was to climb just 2 minutes of stairs per day, we could actually eliminate the average weight gains that we see in US adults. There's a Harvard alumni men study of over 10,000 men. They followed these men over a 13-year period, and they asked them about all sorts of things in their lifestyles. The men who climbed 20 to 34 floors of stairs per week, if you divide that by 7, that's only 3 to 5 floors per day, they had a 29% reduction in the risk of stroke. And that was independent of whether they exercised in leisure time. So these daily things done every day in daily life are actually really important in shaping the ultimate health outcomes for us. And there's a whole host of things we can do to increase stair use, right? There's simple signage placed at points of decision, like in front of the elevators and outside of stairwells, can increase stair use by 50% on average. And many studies showing this now. If you design stairwells to actually be pleasant through music and art, if you can see them when you walk into the building so that you know where they are and they're available and open, those are all things that increase stairs. Also, in very high-rise buildings where people may not want to walk 40 stories, there's something called the skip-stop elevator. You can program the elevators to stop at every third or fourth floor, not at every floor. There's a number of buildings in the United States now that have been using this. In California, a study was done in those buildings, and they showed a 3,300% increase in stair use. Something like over 70% of the people in that building use the stairs every day. At the same time, we also need to look at the food environment. That's the other side of the equation. What is food retail like in our communities? Are there healthy food outlets like supermarkets that carry and sell fruits and vegetables and healthy fresh food options? Are there farmers markets? Are there community gardening opportunities? Or are they just selling unhealthy food items and are there just unhealthy food premises like fast food premises? Neighborhood stores that sell only cigarettes, alcohol, junk foods, soda pops. How do we influence that retail environment? And studies are bearing out that having supermarket availability and availability of healthy food associated with better diets, associated often also with walking, because if you have extra destinations where people have to go buy healthy food on a regular basis, they're walking to and fro because it's in their neighborhood. There's actually a study in the UK in an inner city neighborhood that showed that when they opened a new supermarket, they actually improved the walking outcomes as well as other outcomes. High density of fast food restaurants associated with increased weight and obesity. Community gardens, even though community gardens may not provide enough access to all the fruits and vegetables that we need in our communities, there are some emerging studies suggesting that exposure to community gardening actually increases fruit and vegetable intake for both adults and for youth. Access to tap water versus caloric beverages. Caloric beverages, big source of calories in the US diet. 10 to 15% of children and adults' calories, completely empty calories. If you drink a 250 calorie can of soda each day, basically 3,500 calories makes 1 pound, right? So if you just drink one can of those every day and did nothing else, in approximately 2 weeks, you're going to gain a pound, right? So over the course of the year, that is actually 25 pounds. So it's these little things in daily life are actually very important, as I said. At the same time, there are now studies showing, for example, there's a study of schools, elementary schools in Germany, that showed that they took 2 sets of schools in inner city neighborhoods. And one set of schools, they actually made sure that the water fountain was working. If it wasn't working, they installed new water fountains. And they also gave the kids some education around drinking tap water. And in the other set of schools, they didn't do anything. And they found that in the schools where they actually made the water fountains available and encouraged children to drink tap water, a few years down the road when they were following up these kids, the rates of obesity had risen much less in those schools where they had done the water interventions. Now, in addition to the health benefits, from the many sectors that are here today, we have also other priorities for our society. For many of us, we're concerned about the environment also. Well, many of these interventions actually have synergistic co-benefits with the environment. So we most often talked about walking, cycling, transit as opposed to the car for our environmental benefits like fuel use and air quality. But actually, if you think about all these other host of items that we need to do in daily life, they also have implications. Elevators and escalators actually can use significant amounts of energy, especially escalators. I read a statistic that said an escalator running 24/7 can generate 4 carloads of carbon dioxide each year. Stairs, we use our own energy, which is actually good for our health, and it doesn't require electricity. Active recreation rather than television. In New York State, television's very soon going to overtake refrigerators as the main source of household appliance energy use. And of course, in the summertime, if you're at home watching television and kids are at home watching television, the air conditioning is actually turned on full blast as well. And this is actually one of the major reasons on very hot days that we're at risk of blackouts in the United States. So there is this energy equation that's very important. Tap water we very frequently hear, well, tap water versus bottled water is much more environmentally friendly. Well, if you think about all of those sugar-sweetened beverages like soda pops, what do they come in? They come in cans and bottles. And in fact, I suspect that transportation miles may actually even be worse than bottled water, because what about all of those ingredients besides water that went into that can and into that bottle? All of those raw ingredients that had to be processed, shipped, reprocessed, reshipped, rebottled. And finally, produce rather than unhealthy processed foods. If you're eating fresh food, like fresh produce, it leaves very little waste. And the waste that's left, like the apple core, is compostable. If you look at the unhealthy foods that are out there, whether you buy it in the supermarket or in the fast food store, it is highly processed with all of the transportation miles, and it is highly packaged with all of that going into the landfill. Now, another key issue, of course, in the design and creation of our built environments are accessibility issues, ensuring that those who need access to our streets, neighborhoods, amenities, and our building amenities have access to them. People with disabilities, people as they age, so universal accessibility, fundamentally. Now, creating a good walkable realm is very aligned with that, very synergistic with that. Having good sidewalks that have good surfaces, that are wide enough, good street crossings that are safe, that have enough time to get across the street. These all help those who have disabilities and those who are aging. At the same time, our Mayor's Office of People with Disabilities in New York actually pointed out to us that even getting more people who are healthy to take the stairs through better designed buildings is actually important for people who have disabilities to be able to use the elevators in a more friendly way. Very crowded elevators are actually very unfriendly towards people in wheelchairs and who really need them. So there's all of these synergies. There's also economic benefits. So, one of the things that we did with our supermarket creation initiatives was we actually looked at all of the dollars that were flowing out of our neighborhoods and going into neighboring neighborhoods, some of them in adjacent states, outside of our state, because people were going outside of their neighborhoods to purchase foods because supermarkets were not available in their own neighborhoods. And our supermarket development, of course, also entails not only creation of healthy food premises with availability of healthy food, but it creates jobs in some of our high-needs neighborhoods, much needed jobs in this economic climate. In fact, the supermarket creation initiatives for us are actually a joint initiative involving health, city planning, and also economic development. In terms of the subject of creating jobs, this slide basically shows you that road infrastructure built for cars alone actually create fewer jobs per $1 million spent than road infrastructure that includes pedestrian and bicycle facilities. And that is because much more land is needed when road infrastructure focuses only on the car. So monies that are spent on land would otherwise be monies that could be spent on a more intensive infrastructure that creates jobs. Similarly, sprawled infrastructure compared to more compact scenarios, very expensive to build and maintain over time as they age. So there's cost savings to be achieved in better infrastructure that is more compact with sufficient density. And households, social equity issues. There are now studies, these are from the United States, but showing that people who live in auto-dependent neighborhoods on average spend 25% of their monthly incomes on transportation costs. If you live in a transit-rich, walkable neighborhood where you have options, they spend on average 9% of their monthly incomes. So I'm going to stop with all of those benefits and actually move on now to talk a little bit about how we can integrate health into urban and building design policies and practices. And these are lessons learned not from health, actually, knowing these from the start, but actually these are lessons learned from health in New York City and in North America, working with our other sectors and what they've taught us. Those folks in transportation planning, public works, buildings, school construction, housing development. We've learned that there's a need for partnerships across sectors because health does not design or build these environments. And we don't even know where the opportunities are to make the best policies and to change practices. But you guys do. And you can tell us that in each of our communities. Finding synergies and co-benefits like the ones I've talked about, many of those synergies and co-benefits were highlighted to us in health by our partners in transportation and city planning and public works and housing and school construction. There are complementary roles for the partners. So health can show you the statistics that we collect on health diseases, on health risk factors. We can tell you about the studies we know about in the health literature, but we really rely on our partners to tell us where those opportunities are to make change within their practices and professions, within the policies that they have control over. And in fact, that's what we've done in places like New York City. Researchers play a key role with us in synthesizing the evidence, in helping us to do further research on innovative items where we can collect more data through evaluations to then show effectiveness and more evidence for different sorts of things. We've used evidence-based and best practice strategies. And we actually have annual conferences called Fit City conferences now in New York City to celebrate the successes of our last year across all our sectors who are involved, and to actually see what we can do strategically in the next year to continue to make progress. If any of you are going to be in New York City, June 24th and 25th, we have our 8th annual Fit City Conference. And you will hear when you come to that conference, if you come to that conference, from probably 9 or 10 city commissioners from not just health, but across the sectors involved in the design and building of our built environments. So these Fit City conferences, as I talked about, we used the first Fit City really to brainstorm ideas across our different sectors. We then took those ideas and actually created intersectoral initiatives that were co-led by the relevant agencies. One of them is these active design guidelines. You can download them at the URL at the bottom. That basically gives evidence-based strategies for best practice strategies for creating a healthier urban environment and also a healthier building environment. There are also key synergies that are highlighted that include an innovation credit that has been created for our Green Buildings Rating System, LEED. And so that's something that potentially could be adapted to your Green Star system as well if it's not already done. These are all of the agencies involved. It was co-led really by 4 agencies: Health, Public Works, which is our design and construction department, transportation and city planning. In fact, the idea for the active design guidelines came from our commissioner of design and construction, or public works. He basically said, hey, you know, we've got a whole host of guidelines out there for universal accessibility, for environmental sustainability, for more efficient water use, for better lighting. You know, this seems like a pretty important issue in terms of the cost to people and to society. We can create a set of guidelines, you know, within this whole series of guidelines that actually addresses this issue. And so after Fit City 2, where he said this, he's like, calls up health, he's like, let's form a working group. You know, then we call up transportation and city planning, and as a core group, we got to work drafting these documents. Health actually was able to assign a coordinator to the process to help with organizing the meetings, drafting some of the work. We actually ended up getting a contract, some subcontracts out to researchers to help us synthesize the evidence and update the evidence. And then when we finished, we actually then, the draft, we circulated it out really to a total of 12 city agencies to say, hey, you know, does this address your needs? Are there things that are missing? And by the time we were done, we had 12 city agencies that had written sections of the guidelines, given inputs, and became a 12 city agency document ultimately. And then we invited actually the private sector architects and planners and developers to also come to a design charrette with us to give their inputs. And they did, and the result is then this document called the Active Design Guidelines. Here are some of the types of strategies that are in there. This is clearly not a comprehensive set, but land use mix, critical of course if you're going to have walkability, and as part of that land use mix, thinking through the access to healthy foods like supermarkets, farmers markets, drinking water in the public realm, play spaces, parks, playgrounds, pedestrian plazas as a part of that mixed use. Transit access is key. In areas underserved by the subway, we have been in New York working hard to increase bus rapid transit routes in those areas, and despite already high transit ridership, have continued to increase transit ridership through these systems. Pedestrian-friendly environments, bicycle networks, and infrastructure. And of course, complementary items within the site and building scales. Bicycle parking and storage when you get to your destination. Active recreation spaces for children and adults, particularly thinking about some of our multi-residential affordable housing. Particularly if there are no parks or playgrounds close by in some of our inner city neighborhoods. Stairs we've talked about, and then of course also access to tap drinking water within our building, worksite buildings. So in New York, these are some of the things that we've done from a policy perspective. Plan YC, some of you may have heard of Plan YC, it is our master plan. We realized that there's going to be population growth from the 8 million that it is today to 9 million by 2030. With that population growth, our anticipated impacts on housing, i.e. the lack of it, affordable housing, i.e. insufficiency, traffic congestion on the streets, and the need, therefore, for thinking through our transportation systems, environmental issues for more and more generation of carbon. And so it has become our master plan to address these multitudes of issues. The first version of Plan YC was released in 2007. It had a whole host of things. Parks and playgrounds within a 10-minute walk of every home was one of the targets. Increasing alternate modes of transportation besides the car, improving transit, improving walkability, improving cycling paths, increasing housing and affordable housing. So all of these were a host of things that were going to impact health. Health was not explicitly mentioned in 2007 because the work that we were doing around active design began at around the same time. So I went to New York City in mid-2006 to start this work with them for the health department. But by 2011, from working together, we realized how much overlap there was. And in 2011, Plan YC released version 2. It has actually a whole chapter dedicated to public health. And public health now is a running theme throughout the Plan YC version 2. I think our partners at the Office of Long-Term Planning and Sustainability also realize that the public actually cares tremendously about their health and the health of their children, so why not highlight these benefits also within our master plan? Smart growth, of course, is a key approach with transit-oriented development, thinking through density and mixed-use issues and walkability issues around transit nodes. For those of you who may have come to New York City in recent years, you may have seen the form of our public right-of-way change so that more and more streets fundamentally are complete streets. You could see the bike lane on the left, and the bike lane actually, initially we used to paint our bike lanes. We had sidewalk parking, then the bike lanes. And then our transportation and planning commissioners went to Copenhagen and to Europe for a tour. And they came home and now they're painting bike lanes this way. With the sidewalk, then the bicycle lane, then a little bit of a painted buffer, then the parked car, using the parked car and a little bit of painted buffer as the protection. So we fundamentally created protected bike lanes without any additional infrastructure costs other than paint. And then you also haven't taken away parking on the streets because there remains parking on the streets. And then, of course, bus-only lanes, which I've also seen here in Sydney, for improving bus rapid transit. The other major thing that we've done is as part of our 10-minute to parks and playgrounds from every home's goal is, where we do not necessarily have enough space to create parkland itself, we've been building pedestrian plazas. Pedestrian plazas, can be in small ones in very local neighborhoods, such as this one in Brooklyn, very inexpensive to create with paint and plant potters, basically. Initially when we began the pedestrian plaza program, there were lots of concerns. Can this work? Will the public like it? And, we basically said, well, let's try it. I mean, it's really only paint and plant potters, right? So if it really doesn't work, if people really hate it, we could take it away. But of course, once you create these public spaces, neighbors come out, they're meeting each other, there's gathering, and they love it. Similarly, in Times Square, these large pedestrian plazas are also being built. You know, it used to be that the bulk of the people on the streets were pedestrians, but 89% of the road space was really for these vehicles. And we created these pedestrian plazas. Again, you know, the taxis were very concerned about traffic congestion, et cetera, and we said, well, let's try it for a few months. It's only paint and plant potters. And so we closed these off and evaluated outcomes, and these are the types of outcomes that we saw. Basically, pedestrian volumes up, even though these places already had high pedestrian volumes. But we also looked at other things that were of concern, like retail. Retailers were concerned if this was going to impact, you know, their bottom line. And in fact, you know, when people are on the streets, they walk into the store. When they're actually driving with no place to park, they're not stopping to go into retail. So retail is up in Times Square. In other areas like Union Square, where we've improved the pedestrian environment, there's been a 49% drop in vacant storefronts compared to other areas where we have not done this, where the drops have been maybe something like 5%. Here are some examples of other things that have been done to improve the streetscape for pedestrianization. So this is something that our city planning department has undertaken. They found that, you know, in many of our residential streets, one of the things that was occurring was the flow of the pedestrian sidewalk was constantly interrupted by driveways for cars that created curb cuts. So they actually amended the residential preservation text in the zoning code to cluster the design of those driveways. And as such, you're able then to decrease the interruption of the flow on the sidewalks. The other, of course, is when car share became something that could be introduced to New York. City planning was highly involved in using the zoning resolution to find places to locate and park these car share vehicles. And studies show that, you know, car share vehicles really decrease the demand for the number of private vehicles on the road. As part of land use mix, you can see here, this is the High Line. I don't know if some of you might have seen the High Line. Excuse me. This was a railway, elevated railway that was abandoned for many, many years. The city decided to rezone it for development, also invested money into redeveloping it. And basically, you know, I heard the figure of something like the investment was something along the lines of $100 million, and it's since reaped back something like over $2 billion in terms of real estate taxes, retail taxes, and all other sorts of revenue. This is the High Line. And of course, the commercial and residential properties around them have boomed. Waterfront plan that creates basically access to the waterfront for recreation on the water as well as next to the water. And many of these greenways next to the water are actually also used as active transportation corridors for people who can easily access them. And then, of course, you know, the food equation as well. Healthy versus unhealthy food and beverage premises. Trying to creating more healthy food and beverage premises while decreasing the unhealthy one. Food retail expansion to support health is our initiative to create supermarkets where there are none and where there are few in our underserved areas, many of which are actually also our highest needs areas. This is a set of actually zoning and tax incentives that makes it more feasible for supermarket operators to locate in high needs neighborhoods. The incentives were developed after extensive consultation with supermarket operators, hearing their needs. They involve actually thinking through store size, decreasing parking requirements for supermarkets, because, you know, many of our inner city neighborhoods, people don't own cars, and it's close enough for them to walk to. Tax incentives include real estate taxes and land taxes, considerations for mortgage tax deferrals, and also on the materials that would actually be used to create or expand supermarket infrastructure. There's a sales tax exemption. So with that, I mean, we really only began the FRESH initiatives in 2008. It is a partnership between health, planning, and economic development. It's created also many jobs now. We have had 3 supermarkets already open, and we have 8 more in the pipeline that are being now constructed. Green carts. Green carts are actually a new category of food permit that we decided to create because we have a very long lineup, actually, for street food permits. And so we decided to create this new category that would allow people on the lineup to basically say, you know, if I'm willing to sell fresh fruits and vegetables only through my street cart, and I'm willing to do it in the areas underserved for fresh fruits and vegetables, I don't have to wait on this lineup for I don't know how long to get my street food permit. I can jump the queue to this new set of permits. And so it serves multiple benefits from the economics for those who want to create these food carts and have a food cart to serving underserved neighborhoods with fruits and vegetables. Another, of course, is community gardening. This is a rooftop of an affordable housing facility. Gardening, of course, creates both opportunities for healthy food as well as physical activity. And there are things that can be done, right? Particularly around green roofing, whether it's making easier to have green roofs, but ensuring that we pair, I think, green roofs with functional outcomes like community gardening or like physical activity facilities, particularly in neighborhoods where there may not be sufficient space on the ground for some of these activities. Access to tap water in both the public realm and our buildings. So thinking through our parks, our streets, do we have tap water access? If people don't, they're going to be either buying bottled water or bottled and canned beverages, which are also unhealthy and highly caloric. The other thing that we've done is, as part of our greening of our construction codes in New York City, we have passed a set of water efficiency bills. Part of those water efficiency bills included improving tap water access in our worksite buildings, the tap water facilities in our worksite buildings. So there are actually ways to integrate, I think, these health elements into many of our greening processes and many of our policy processes such that they become a part of the package. Of course, stair promotion, these simple signs we worked with the American Institute of Architects as well as the Real Estate Board of New York to create and to help us distribute to their membership. And we are happy to say we've distributed over 30,000 of these. And they're probably in over 1,000 buildings now. And these simple signs really increase stair use on average 50%, as I said. There are many, many studies now showing this. Bicycle networks, of course. And in addition to the lanes themselves and the connectivity of the lanes and their connectivity to destinations, then places to park your bike when you arrive. Transportation and City Planning worked very hard to help us pass a zoning a requirement for bicycle parking in new buildings, both residential and commercial. The requirement is paired with a floor area discount for the bike storage area so that the developers are not penalized for having this bike storage. Bike share is coming to New York City in 2013, so this upcoming year, and health is working closely with transportation to undertake the evaluations around health. We program our streets by closing our streets to cars temporarily and using them for active play and active transportation. So some of you may have heard of summer streets. They're modeled after the ciclovías in Bogota. We have them on Saturdays in August, and the 7 miles of Park Avenue from Brooklyn Bridge up to 72nd Street and then connecting into the 6 Mile Loop in Central Park are closed on Saturdays for people to come out and bicycle, walk, for kids to play. There are exercise stations along the route. There's, tap water for you to drink connected to our fire hydrants, and there's no food sold. There's bicycle repair stations, so it's really meant to be a physically active opportunity. And health was involved with transportation on the health-related evaluations. You could see that over half of a person's weekly recommendations for the people that we surveyed were being met by coming out to the Summer Street site. And on top of that, that was excluding and not even including the approximately 90% who got there by active modes. We did find, though, that some of our high-needs neighborhoods in the outer boroughs were underrepresented. at the Summer Streets route. So we went back to DOT and we said, hey, you know, what can we do to actually expand some of these street closures out into some of these high needs neighborhoods as well in the outer boroughs? And DOT said, you know, I don't think we can create a route kind of long enough to extend into all of those areas, but we can create a new category of street permits for play streets. Play streets are now these single blocks of streets on quieter streets that are closed to cars, and they're made available really for community groups in areas that don't have enough places for active play to close the street at set times. So it can be weekly through the summer, or it can be daily through the summer, for kids and families to come out and play and to meet each other and to socialize. The other, of course, is schools can use this as well during the school year. If they don't have enough gym space for PE, physical education, or active recess, they can close off their streets at designated times daily for their kids to come out and play. DOT sets the criteria. They have set criteria for what makes such a safe street. Health actually has a coordinator who provides technical assistance to the schools and to the community groups that want to apply for this permit, and then we work with DOT to get them permitted. You could see that children are coming out for significant periods of time, and if they weren't coming out, the parents are reporting that they most likely would have been inside watching television. And I need to wrap up. Another thing I think just to say is that in addition to legislative processes like the zoning changes that I've talked about, there are clearly things that can be done within administrative processes of our public sector as well. Our school construction authority, our housing folks, our economic development folks, our design and construction of public works folks now routinely integrate the active design guidelines and strategies from them into their standards and guidelines for their own design and construction. They include them in their contracts and in their requests for proposals that go out for consultants and contractors. And we've been working with the leadership across all our city agencies to train our staff so that they can implement the projects. I mentioned LEED and the LEED Innovation Credit. So thinking through also green rating systems like Green Star and whether they sufficiently address the health issues. And if they don't, then perhaps those of us who work in health can assist you with that. United States, across the United States, you know, we now have over 50 communities doing this work, 50 cities doing this work on improving the built environment for health. They're funded by the Centers for Disease Control to do this. The Centers for Disease Control no longer funds health education efforts. All the efforts that they've been funding in recent years because of the effectiveness, focus on systems change, policy changes, environmental changes. New York City's been mentoring about 15 of our communities across the US with an additional grant from the Centers for Disease Control from coast to coast. And these are the types of partnerships that we're seeing across the cities. Health, planning, transportation, really key, but also school construction, parks, public works, housing, and buildings. And this is the last slide. And you know, in the very short time that we've been doing this work in New York City, we have really been able to actually impact outcomes to our surprise as well. Pedestrian volumes up, as I showed you earlier, even in high pedestrian areas, stair use where interventions are being undertaken, commuter cycling up nearly 300%, bus and subway ridership up despite already high rates of that, places for children's play up, decreased at the same time, decreased traffic fatalities, decreased traffic volumes, and decreased car registrations. We've started reversing the childhood obesity epidemic in New York City, as has a couple of our mentee cities, San Diego and Philadelphia, both of which are also taking a comprehensive environmental approach to improving these issues and the positive environmental and economic impacts that you've heard about. Thank you very much. Thank you for your attention.
Well, that was really inspiring, wasn't it? I mean, and what really impressed me was the amount of cooperation between the different agencies to really implement some really good ideas. And they're not just good ideas because there's fantastic outcomes, and that's really proof in the pudding. So we've got a little bit of time now before morning tea, about 15 minutes for some questions, if anyone would like to ask Dr. Lee any questions about her presentation for now. And while you're thinking of it, I'll ask the first one, it's Chair's prerogative. and really focus a little bit on the cooperative aspect, because in the design of the guidelines you had a number of agencies. Health facilitated the development of it, and I was really interested in, have you got any tips for us about how to increase the level of cooperation between the different agencies, because that seemed to be a really effective aspect of what you've been doing.
One of the things that we've been doing in New York is these annual conferences, right? And in fact, we began our work together with this annual Fit City conference. And, health really presented what it knew, which was, the health statistics that you've seen, the research evidence that we're aware of. But we really asked our other sectors for the ideas that they had around what we could do within their individual sectors from both a practice and policy standpoint. And, that would actually also have co-benefits for the types of other outcomes like environmental sustainability or universal accessibility or economic development that were also so important to their sectors. And I think a really key part of the success has been, our other partners in sectors outside of health telling us where those opportunities were, giving us those ideas, and then, willing to basically come to the table when we had working groups to co-lead the intersectoral initiatives. And I'll say that, since we began this process about 7 years ago, our other sectors have really just taken this and run with it as well. So, for example, in our Public Works Department now in design and construction, they now have dedicated staff who do active design work and whose role is to ensure active design gets integrated in every single one of their projects. The residential text amendment to improve the pedestrian streetscape, our city planning took that on their own. They said, this is something we can do, let's do it. So I think, it's really very much a co-leadership structure.
On your last slide, you say there was an increase of threefold increase in commuter cycling. I wonder, would you know the percentage of trips for transport that are done by cycling in New York City?
Well, for us, I mean, we have, these are done actually through screen line counts that DOT does at specific areas. In terms of population level use of cycling, when we began this and were collecting data on this, we found that actually less than 1% of our people cycled at all, And so now we're probably up to about 3%. So we've got a long ways to go, because I think Portland is still at Portland's at 8% now, right? And so we've got a long ways to go, but we are rapidly increasing it and pleased with it.
Okay, there's two more. There's one here and then one up here.
Thanks very much for your presentation. I was wondering about one of the other key impacts on individual households and obesity is actually household income. Were there any things that were particularly looking at issues where poverty was a main issue, and how was that being addressed?
In all of our surveys, we are, we actually oversample and oversample the areas that have our highest needs neighborhoods. And in those neighborhoods, we do find, as you say, that, health outcomes are poorer, and we see health disparities. Well, one of the ways that we are trying to address health disparities, so there's two ways to do it in public health. One is we actually have health programs that target our highest needs populations. The other way is actually through policy change that will then ultimately impact the minimum standards across our environments, right? Because they disproportionately will help people who can't buy their way into a better environment. So for example, if we can create better standards for affordable housing around healthier environments, then you don't need to actually buy expensive housing in order to have that healthier environment. So we see the built environment actually and minimum standards and improving of the built environment across the board, particularly in the public realm as well, as one way in which we can impact those health disparities.
Thanks very much for your presentation. Just a question relating more to New South Wales, but in New South Wales there's a bit of a political maxim that increasing environmental regulation what's unfortunately often euphemistically called green tape, discourages developers from actually developing, and actually growth, particularly in things like housing. I wonder, have you found, with all of the reforms you brought in, particularly in zoning and in regulation and so forth in New York, has that discouraged at all growth, or has it impacted on that at all? And are there any statistics you can point to actually show either way?
Well, I think, I've shown you some statistics around some of the actually very positive economic outcomes, right, that you've seen from the developments of things like pedestrian plazas, of, the development and creation of the Highline Park. So I think that there are things that certainly can be done that actually have multiple positive outcomes, including for economic development. I think very frequently when we think of policy, we need to think of policy, I think, very comprehensively. Regulation clearly is one side of it. And where you cannot, I think where you need a set of minimum standards or a level playing field, then regulation is completely, I think, appropriate. But there are also, as you've seen, things that can be done to incentivize, right? And so policies involve also like this whole gamut of policy tools that I think can be undertaken, from regulation to creation of incentives, which are actually also can be legislative processes. And, as you saw from the requirements for bicycle parking, that the passage of that bicycle parking law actually required that combination of mandating plus relieving the FAR. So we're trying to use, I think, where we can pass mandates and regulations, we do. Where we can't, we're looking at incentives. But there's also, I think, government administrative policies that very frequently don't require a legislative process, right? Like the standards, what goes into your contracts for development or for your contractors, the standards that guide your own design and construction processes. Those are things that actually can be looked at and potentially updated or can integrate health without needing a legislative process. So I think, the whole gamut of items need to be looked at. When we look at the LEED certification system in the United States, we see that a lot of market rate commercial and housing properties have taken that up voluntarily. They've taken that up because they see it as being good for their marketing and good for their reputation. So I'm not sure that, doing something that is good for the environment and doing something that's good for health is necessarily bad for the bottom line. And I think we really need to be very cognizant of framing things in a way that it's not this or that, but rather that we can do this and that at the same time. And in many cases, that's possible.
Right, there's a question here.
Thank you for your enlightening presentation. I'm just wondering if there's any part of the program that you've been able to marry with an ageing population, particularly the walking, cycling side of things, the active living. You talked about encouraging usage of stairs and whatnot. Sometimes the elderly have a bit of a mental block in terms of going the extra mile physically. With the active design guidelines, one of the 12 agencies, as I said, that gave inputs into it was the Department for the Aging. And certainly the issues of an aging population is a really important one. As our commissioner of the Mayor's Office of People with Disabilities would say, it's not a matter of if we will have a disability or who has a disability, but when we will have a disability. Because all of us, of course, will age over time, and at some point not be as able-bodied as we are at an earlier stage in our life. So some of the key things that I think I mentioned include, for example, a very walkable realm that has actually good wide sidewalks, that has good surfacing, that has good safe street crossings are all fundamentally key to
people who have disabilities or people who are aging continuing to be able to use the streets to access the goods and services as well as physical activity. One of the other things, of course, that we're doing in New York is we have a City Bench program. The City Bench program actually is working to create, it's located within our Department of Transportation. It's working to create more street benches throughout city streets, because we recognize that, you know, as people age, I mean, they can't necessarily walk to their destination and back without stopping and resting. And so having places for people to sit and rest on the streets and in our public realm is really important. Similarly to our parks, having benches for people to rest, so they may walk for a while or do some activities, but then needing to sit and rest. And then in terms of, you know, as I mentioned about stair use, I mean, the interesting thing I think about, you know, undertaking active lifestyles is that it will, you know, decrease the onset of early disability from early disease and early conditions. And so that in itself will, you know, assist, I think, with the prevention of some of these diseases or the delaying of some of these diseases and conditions later in life. But, you know, as I mentioned as well, freeing up getting able-bodied people to use the stairs is something that frees up the elevators for those who actually need it. And that can include people who are older and who use a cane, who can't climb the stairs anymore. I think the other piece, of course, is the use of ramps, where you can put in ramps. That's a fantastic thing to put in. But, you know, of course, they take up a lot of space and is not feasible as a primary mode of circulation across all levels in all of our buildings.
Okay, I think we've got time for one more question. I saw a hand up down here, so this will be the last question.
Thank you for your presentation, and I'm just amazed about, you know, all the different initiatives you set in place, and you were very successful in increasing the physical activity. But I'm just wondering if you can tell from your surveys if you were able to increase physical activity in the less active group, or if it was just the more active people who just grabbed another opportunity to be more active.
Yeah. One of the issues with our surveys is that, you know, one of the issues with our surveys that we do every year is that it is a survey of 10,000 New Yorkers, but it's a random, you know, it's a random digit dial format. And so people are not being tracked longitudinally over time. So that's, you know, so then it's difficult to, it's more difficult to do, you know, necessarily those analyses. I was going to say that in our summer streets evaluations, for example, we did find that, you know, what I presented as the meeting half of your recommendations for the week, that is across all of the participants. And we did find that, you know, about 1/4 of the participants who came out were people who were insufficiently active during the rest of the week. Yeah, so we're trying to get at that data, but it's not always necessarily simple.
Thanks very much. Thank you. So please join with me in thanking Dr. Lee for a fantastic presentation.